Understanding and addressing value from the front lines to leadership is essential to improve outcomes, enhance the patient experience, and reduce cost. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, Senior Writer with AHA. Brought to you by the American Hospital Association's The Value Initiative and Physician Alliance, the Value Rounds podcast series, Working Towards Value Together, will feature leaders from the field to explore how clinicians and hospital leaders must work together to address healthcare value and affordability. Joining us today for part one of the podcast series is Priya Bathija, Vice President of Strategic Initiatives at the AHA, in conversation with Dr. David Perlstein, Chief Executive Officer at SBH Health System. They are joined by Dr. David Zaas, Chief Executive Officer, MUSC Health, Charleston Division, and Chief Clinical Officer for MUSC Health.
Thanks, Tom, and thank you, Drs. Perlstein and Zaas, for speaking with me today about how clinicians and hospital leaders must work together to address value and affordability. Let's jump right in. Hospitals are continuously working towards improving value, which we have been defining broadly to include strategies that lower cost, improve outcomes, and enhance the patient experience. How do you view value in your role?
This is the nice thing about everybody being called David, is that no one really know who we are, which is, I think it's great. And this is David Perlstein talking. So, I think as a leader of a healthcare organization, my primary role is to drive value, or one of my primary roles is to drive value. And I define that by enhancing the patient experience. And I include reducing waste, improving outcomes in that experience heading. In other words, I think we always have got to try to keep the patient at the center, and we have to continue to push and pull as needed and desired. Having said that, we always talk about being patient-centered, but in general, most of us fail pretty badly because so much of our service delivery is designed around our institutional and providers' needs and capacity. In other words, it's really hard to transform a culture from being provider-centered to being patient-centered. And we struggle with it just like everyone else. We work tirelessly to find the right balance to support our care delivery team while putting the patient first. But the outcome, in my opinion, isn't always ideal. And often we end up basically with both groups that are not maximally satisfied. So we work on working on a sweet spot, or trying to find a sweet spot where both patients and providers feel satisfaction. And I think that often that means you got to remove barriers. You got to simplify your processes. You have to communicate, but communicate realistically. Everyone always says under promise and over deliver. I think you have to promise what you can deliver, and you have to communicate failures honestly, and meaning apologize when you can't deliver. And you have to work on becoming highly reliable, and you got to listen and learn. So I think that's my 2 cents.
So I could not agree more that we really need to define value and put the patient at the center, as you mentioned, David. My only concern is value the right word? Too much of when we think of value today, everyone jumps to just lowering cost. And we know that that's not the definition of value, but I worry in our community and across healthcare, when we think around value, we automatically jump to cost instead of saying, right, the highest value care, right, first has to be the safest. It has to be achieving all of our goals of high reliability and zero harm. It has to be achieving the best outcomes through the highest quality and how we measure those outcomes. And maybe equally important is it needs to be the best experience, as patients and families are our customers in the most important way. And we need to deliver on all three of those at the same point, we do need to do the right care at the right time to ensure that it is the lowest cost and the best use of our resources. But I think we need to really focus on the value conversation. First is achieving the safety, the quality outcomes, the optimal patient experience, and all done at the right cost and the right location, focused on the patient and family needs. And I don't know how we continue to make sure we focus on the patient as well as the cost, but not let cost dominate the equation.
Yeah, I think that's a really good point. And, Dr. Perlstein, you were in a COVID hotspot, and, that's what we're currently dealing with in the pandemic that we're in. And from a clinical perspective, how do you think value is going to be viewed by patients after the pandemic? And do you think it'll change how they want to engage in healthcare in the future?
Oh, I absolutely do. Honestly, I think it's totally upended the healthcare delivery system. It's also pulled back the curtain on the inequalities that exist across systems. But I'll tell you that primarily it's going to have an impact on how we communicate and facilitate services. So telephonic and video visits are the present and the future of the care that we're going to deliver, and I do expect the majority of our patients will continue to want this. And in fact, it's pretty amazing. Our show rates on our non-in-person visits are closing in on 90% to 100%, which is something I never could have said before, given our population. And that is a reflection of not being patient-centered, of course, because I'm giving them appointment times around probably times that are not great for them. And then really, why do I think the telephonic and video? Well, it's pretty efficient and effective. Less travel, especially for my population, which is primarily a poor, a population, urban population. It's mostly a community of color, very high poverty rates, and it takes a lot to get to the provider. So I have patients that have to get on a bus or two and potentially a subway and then walk in order to get to their appointments. And I'm telling them when they have to be at their appointments. So I certainly can save everybody time by just having them stand by a phone or a computer or a handheld. Of course, you have to continue to stratify. So we have identified patients that want to come back. They like coming back. They like the in-person experience, and sometimes it's their only real social experience. And so we will probably have to accommodate those folks until we can identify a better way to socialize them without putting them in a high-cost area. You also have to identify who needs and wants that in-person visit and who needs an alternate level care. But the real challenge that our communities have are trying to make sure that all communities are going to have the same access to technology. And I would argue my community does not have the same access. It doesn't have the high-speed access. It doesn't have the infrastructure. And in fact, another challenge that we also know has been identified is because I have households that are either multifamily households and certainly very few people that have their own space. We're even struggling to get adolescents to participate in telehealth because they can't really be honest over the phone because they're surrounded by brothers, sisters, and aunts and mother and father. So we have to even deal with the fact that we're going to have to find a safe place to continue to have this practice in place. But I do think, and it's a good thing, that we are going to be able to finally use telehealth in all communities.
So I think healthcare has changed so much in the last few months, as David points out, although I hope that it continues to change even faster. The COVID crisis has taught us so much. The health disparities impact has been so significant on so many of our communities. And I think it's a call to action. I think it has to be a call to action for all leaders within healthcare, as well as within our public service communities, to think around how are we going to impact those socioeconomic determinants of health, that our vulnerable populations are not so disproportionately impacted. And I don't think we've solved that yet. But I know many of us are shocked by the degree of health disparities that COVID has unveiled. I think telehealth is part of the solution, although we all have entered into telehealth, and in some ways we've recreated our prior delivery system, but we've moved the visits from the clinic to home. And I would wonder, are we going far enough? Do we need to be more disruptive? Our goals need to be, right, how do we really lower the total cost of care? And we really probably aren't impacting that yet, because the high cost care is still being delivered in our hospitals. Mm-hmm. So how are we going to use telehealth to really lower the cost of care by caring for higher acuity, greater complexity at home? The other question that I think about a lot is, again, we've recreated our prior system at the home. Mm-hmm. Does the whole system need to change? Do we need to look very different of how we schedule and how we access and how we deliver services, rather than having virtual clinics? Do we need to really be more like many of our technology companies and approach the customers differently, not just with virtual health, but a really different way to access it in real time, maybe without scheduling appointments, in ways to say, how will our community access it, and how do we ensure that some of our vulnerable populations have that same access to real-time, both virtual and inpatient care?
Mm-hmm.
Yeah, I couldn't agree with you more, David. I and again, it is my population that we care for, and in fact, I totally would like to push the envelope on here, and I do think that it would take our getting outside our comfort zones and trying to explore alternative ways to actually reach our goals, because I don't think we do that very often. At the same time, the investment that's required in my community to ensure that my patients will have the same access as wealthier patients is going to be a lot, and I haven't seen the will. Nationally, not even locally, I haven't really seen the will, and I am worried that we're going to go back as quickly as possible, because in those organizations that have a lot of commercial payers and are able to make money, have a net income that's positive, are very excited to get back to fee-for-service and volume. And for me, and maybe for you, I am much more interested in getting to value, because I'm 88% Medicaid. The volume is not going to keep me solvent, and I haven't seen the outcomes for my patients to justify it anyway.
I couldn't agree more, and I think the burning platform for leaders within healthcare and understanding how we do this differently to allow everyone to access our services is really there now. And if we don't, I worry that new entrants are going to come in and deliver care where it is available through your phone, without an appointment, in real time, in different ways than we traditionally do. So I think we need to align our funds flow model with our goals to improve the health of the communities that we're fortunate to serve, And I think that the door is cracked open for telehealth, but I think we should be more ambitious, that we can do significantly more to lower cost and to improve access for all patients through telehealth. But we need to think around, how do we do it differently? How do we innovate? And how do we empower our teams to really do those experiments so we can learn what patients and families want from our healthcare systems?
Mm-hmm. Well, you have both been, as clinical leaders and as other clinical leaders around the country, really key drivers of the value conversation in the past. And how do we connect that conversation around value that has been happening with some of these broader change efforts in healthcare delivery, whether that's payment reform, care models, or like you were talking about, changing how we think about telehealth and finding innovative ways to do it. What is the clinician role as that progresses?
Hey, Dave, why don't you take that one?
So I'll start on this one. I think the clinician role and the hospital leader role are the same here, right? We need to be the advocates for our patients, our families, and our community. We have an opportunity, especially after COVID. The respect for our healthcare system is higher than I've seen throughout my career. People are now recognizing the importance of the work that our delivery teams are doing, and our patients and our communities, right, are paying tribute to our healthcare heroes in so many ways. How are we aligning ourselves with our patients, with a voice to our managed care payers, to our government payers, which are the majority of our business, to ensure that we are aligned with patients and families to allow the right thing to motivate our decision making, not the funds flow system that we know is currently flawed. Mm-hmm. So in addition to pushing for the reimbursement for telehealth visits, we need to continue to push for funding to do the experiments around other innovations that will change care delivery, different provider types, different locations of care, and we should measure and be held accountable to the data and our outcomes. But I think the opportunity now is the respect and understanding of what we do from our communities has never been greater. So I've really encouraged our team. We need to align with our patients, our families, and our communities to ensure that we do the best in order to meet their needs and improve health. And I think we have an opportunity now that we probably didn't have prior to COVID to try to do that.
Right.
Yeah, I agree with you. I think that COVID has again drawn back the curtain, but also opened the door for us to actually do something much more meaningful. And I also agree with you. Medical school applications are up, which again is very promising to me, because it's telling me that there are more people who want to go into the field for the value of the service. But I think it also is important to make sure that all providers have skin in the game. I think up to now there's been a lot of lip service about it, but I think that one of the things that I have enjoyed watching, at least in New York, is the discussion about more collaboration for the first time ever. In New York, that we have 5 large university systems minimally. And everybody's fighting for the same patients, and everyone's fighting for the same philanthropy. And that really didn't help us, not in this setting. What we started to see were individuals actually having conversations with one another, this is at a leadership levels, trying to identify the best thing for populations. So I think that we have to develop more collaborative care that's aimed at improving the health and wellness of entire communities. It's got to become the priority, and not just about competing for the money. The fact the fact that our healthcare system looks more like a market-driven sector. It's driven by profit margin, market control, rather than my maximal social good or maximal improvements in health and wellness. I think it's a real problem. And I think that if we were to finally focus on patient-centeredness and looking at the outcomes desired, because what we're doing now is not that, we would have savings, because the collaboration would result in less redundancy and waste. But I also think that we have to refocus our effort on addressing social determinants of health, as you mentioned earlier, because you have to level out the health and wellness gap. Because I'm not going to change the fact that my hospital, my ICU, is the most expensive care until I can control the fact that I'm admitting a ton of patients with late stage, ambulatory sensitive conditions, almost like asthma, terminal asthma, COPD, hypertension that results in strokes because it's not been controlled. And we have to start early and address all of those things that impact that health. And it's a big issue, but it's also very complex. And I started talking about it earlier when I was talking about COVID and care, and I can just, an example is just housing in New York. 20% of New York City population live in poverty. Most of them are persons of color. 90% live in overcrowded conditions, which means you can't avoid your roommate or your family or anyone else, which is why I think in part that COVID ravaged communities of color. And then also we've all benefited from, as we mentioned, from Zoom and telehealth and all these things, but a lot of households in communities of color and poor communities don't have access to these things. It's going to be really hard, again, unless we start at the beginning and identify that there are major changes that need to occur in our communities. And it has to be, and everybody has to have skin in that game, right? I cannot go back to a point where my wealthier colleagues in the industry go back to just fighting for rich patients, because that's not going to change the care that's being delivered to anybody. And so unfortunately, I also have seen this a lot. I'm going to continue to work hard to make these changes, but I have already seen elements that are concerning to me, even in New York, just in terms of the way folks seem to be, putting on their blinders again. So I would love to believe that COVID is going to have an impact on this, and I think it will, especially in the telehealth area. But if the problem is so much larger that we have to also really start depending on other experts. It just can't be healthcare trying to fix this.
Right. And I guess another question to both of you is how do we get that scaling to start? How do we get hospitals outside of just your own to think about these issues that COVID has highlighted, such as the social determinants, and making sure, we are providing access to these healthcare services and tech modalities and whatever we're doing. How do we get people to keep that on top of mind as we move forward?
So I'll start a little bit, David, if that's all right. What we have seen throughout COVID is hospitals where they are traditional competitors have come together in ways we probably would never have imagined to collaborate, to share best practices, to share resources and PPE, to understand the data. And I think that's happened around the country in some very traditionally competitive markets where hospitals and health systems are starting to collaborate with each other, and ideally with state, local government around how we respond. the 2 points that I guess I would like to make, and we both feel that the socioeconomic determinants that are so obvious and having such an impact right now are a huge priority. I think our hospitals and health systems coming together can raise awareness. We can catalyze the conversation. We can help align with our families and patients and communities to make sure we talk about it. But we need to be clear that the solution to these socioeconomic determinants is not the sole responsibility of our health systems. We don't have the scale and ability to make an impact alone. We have great expertise, domain experts and knowledge, but we need the support of our local and state governments. We need the support of other business leaders in our communities. This is a societal obligation. And I would hope that leaders out there, both within and outside of healthcare, look at the impact on our vulnerable populations and the impact of health disparities and work with us to make this difference in the future. But we are going to need a much broader coalition than hospitals and health systems, or we're not going to be able to make the impact we need to be. So we should be making those points. We should be trying to influence others. But I think it's important that we can't bear that sole responsibility. We need is to be a much broader coalition.
I think that's a really good point. It builds on what you were saying earlier about collaboration and really making sure that we make that a focus going forward.
No, and I am all for it, and I think that's one of the things that I've really enjoyed are the conversations that I've had with other CEOs in the city, in the community, when we got in trouble. I didn't hesitate to pick up the phone and talk to next door neighbors, and everybody was willing to do whatever they could. Nobody was withholding anything. But again, my fear is now that everyone's taking a breath again and they're starting to go back to their ways. And I think this is where the state and city can step in. And we also would be very dependent on Washington actually having a voice here, and they haven't. And I think it is about leadership. And I think that because we are struggling on that end, I think it becomes a real challenge for us, partly because we can't do it alone. We know we can't do it alone. I mean, the fact is we have to be able to admit what we know and what we don't know and what we can manage and what we can't manage. And we have to bring in that expertise and that and often the teeth that we don't have to control behaviors. So it's a challenge, but boy, we are as close to it as I can ever remember.
Right. And with all those challenges, what advice do you have for your colleagues on how to think about and communicate about value in healthcare?
Yeah, I think that you have to. It's interesting. So it brings me back that the hospital systems have to recognize, it's just the hospital system in general has to recognize its collective vulnerability and accept that in order to be more patient-centered and more efficient, we have to work across networks to optimally deliver care, to improve outcomes, experience, which means you gotta get your collective institutional and personal egos, left at the door, which means you gotta get your boards on board, your executive team and administrative team and your clinicians on team. But I think that telling the story of the successes of the past 3 months is going to permanently change the paradigm, because you're going to see the value of value at this point. And I think it has to happen now, because again, I do see a collective desire to do the right thing right now. So we're in a hurry. And I've asked my team, too, to come up with something that's going to result in immediate benefit so that people can see the result of that and then get excited about it and then keep going. And we had some of that impact with, when we invested in in building housing with a developer. And so we developed, low-income housing. We put together 315 units of housing, and then 90 of those units were homeless housing. And we have a wellness center that was supposed to be open, but COVID obviously stopped construction.
Mm-hmm.
But the whole community got excited, and all of our providers got excited about the opportunities. So I think that is, stories work.
Right, right. Well, Dr. Zaas, what is your last word in terms of advice to your colleagues about thinking about value?
I couldn't be more proud of our team than I've been over the last few months. And I think most of us as leaders in healthcare have seen so much amazing teamwork and commitment to patients and families, as well as the collaboration. So we need to understand how we build on that and achieve the aspirations that David and I have talked about. And I think this is that window of opportunity to rally people around providing the best patient care and really improving not only the outcomes and safety and value. I will share, we've talked about with our teams, we need to be aspirational. And we've talked more that what we need to be thinking of is that perfect patient care. And perfect patient care is the safety, the outcomes, the right location, the lowest cost. And so as we try to think around how important value is, I think it's important that we stay aspirational. So we've talked about going beyond value and saying we need to achieve and strive for perfect patient care, which is both quality and the cost, and realizing that we have a real unique opportunity over the next several months and next several years to really transform our healthcare delivery system.
Mm-hmm. Well, thank you both for being with me today and talking about value and how COVID has impacted that conversation and where we need to go in the future.